Hi there and welcome. My name is Dr. Marlena Jabara, and I'm an American board certified podiatric radiologist. We're going to discuss malignant bone tumors of the foot and ankle. I or a related party have no financial relationships to disclose. Our objectives together will be to provide an overview of imaging tools used to assess all bone tumors of the foot and ankle. We'll review general principles of imaging evaluation of bone tumors, including a review again of our morphology, age, matrix, and location, and we'll take a look specifically at evaluation of malignant bone tumors of the foot and ankle. Again, x-rays, what's the value? We're here to assess the growth rate looking at the borders on x-ray. So if we can see the borders on the x-ray, like in this case of this intraosseous lipoma, we can see they're very well defined. We can find a border around the entire lesion, and that tells us that there's a very narrow zone of transition likely to be benign. We'll be looking for periosteal reaction. That'll be very important when we're looking for malignancies. Detecting subtle areas of periostitis can clue us in that we're into a malignant category. We're always looking for whether or not the lesion is showing aggressive versus non-aggressive features through that zone of transition or the periosteal reaction. And of course, looking for the matrix. That will help us determine the type of lesion we can predict it to be, whether it be osseous, cartilaginous, or fibrous. Again, in MRI, we can visualize the entire bone and adjacent joint. It has excellent superior soft tissue contrast. That's the ability to see within a structure. For example, inside of a blood vessel, we can see that there's a lower rim signal intensity of the wall. So the ability to see inside of a bone, where we can see within the bone itself the different types of elevated signals and changes. That's the definition of superior soft tissue contrast. In malignancy, we'll be looking to identify skip metastasis that can occur very commonly in osteosarcoma. So being able to image the bone from joint to joint will help with the preoperative planning. In addition, we'll be looking whether or not a lesion is close to a neurovascular bundle, something that the surgeon would appreciate knowing before they get towards the surgical site. Looking at the MR signal intensity of tissues can clue us into the lesion itself. Here we can see there's a fluid level, and that is something that is often seen in aneurysmal bone cysts, but also lesions such as giant cell tumors and also telangiectatic osteosarcomas. We can compare the signal intensity seen here to that of intramedullary fat, and we notice that although it's bright as fat, it has some subtle changes along the periphery of decreased signal intensity. And when we go to our trusty charts, we understand that a hematoma can have a high T1 weighted image. We can also have different types of structures. Fat and marrow can be high on T1 weighted images. When it's red marrow replacement, it can be low in signal. Tumors generally are intermediate to low on T1, and we'll be taking advantage of that property. And of course, they tend to be high on T2 weighted images. So we'll be looking at the different features to be able to assess whether or not a lesion has certain signal characteristics that may clue us in that there's either malignancy or aggressive features. CT has superior spatial resolution. That's the ability to see where it is in space. We can see subtle cortical erosions on CAT scan and even subtle calcifications or ossifications, which can help us greatly with the matrix mineralization. That will help us determine whether or not we're in an osseous or cartilage or fibrous category. As seen here, we can see there's some endosseal scalloping in this lesion with no internal matrix. Actually, there's a ground glass type of matrix consistent with a fibrous lesion. Evaluation of the bone neoplasm, our trusty chart starts with that age and sex category. We have single versus multiple lesions that will help us determine what this lesion might be. What bone are you in? The location, the skeleton. Is it in proximity to something like the sternum in breast cancer? What part of the bone is it originating from? Is it in the metaphysis or an end of bone lesion, an epiphyseal lesion? Or is it in the diaphysis, the shaft? Furthermore, is it in the cortex, which we can tell for non-ossifying fibromas? Or looking at the morphology of the lesion, what are the borders doing? Is there destruction? Is there pathologic fracture, periosteal reaction, matrix, or even a soft tissue mass? Again, the age of the patient determines much of the types of differential diagnosis that we encounter. So in the 0 to 10 category, We're talking about eosinophilic granuloma and simple bone cysts. In the ill-defined category, the malignancies might include Ewing's and osteosarc and leukemia. Of course, sclerotic bone lesions, osteosarc in this young age category. It's important to understand this young age category. There are not that many lesions, and they have specific ramifications, obviously, for the patient. 10 to 20, we get into a large group of benign, bubbly lytic lesions. Those span from non-ossifying fibromas, simple bone cysts, to chondroblastomas. Ill-defined lesions in this category, still we're looking for Ewing's, osteosarc, and eosinophilic granuloma to be ill-defined aggressive lesions. More common sclerotic lesions in this category, osteosarcoma, but benign lesions, fibrous dysplasia, eosinophilic granuloma. We can see osteoid osteomas in this 10 to 20 age category and osteoblastomas. The 20 to 40 age category is where the epiphysis closes, and we'll be looking for giant cell tumors. You can also see benign enchondromas, malignant or low-grade chondrosarcomas. Hyperparathyroidism may present, and you may have brown tumors. And of course, you may have osteoblastomas in this category, 20 to 40 well-defined lesions. Giant cell tumors might be ill-defined in this category, and sclerotic lesions may be enchondromas, osteomas, bone islands, parosteal osteosarcomas. Healed lesions such as non-ossifying fibromas, EGRAN, simple bone cysts, ABC, and chondroblastoma. Over 40, we're talking Mets, myeloma, subchondral cysts. For the ill-defined category, Mets, myeloma, chondrosarcoma, Mets, and bone islands for our sclerotic portions. And all ages will be looking for infection in each of these categories. So the age can be an extremely important predictor of what the differential diagnosis is. When we're looking at morphology of lesions, we're going to be looking at the geographic, moth-eaten, and permeative patterns. In this tutorial, we're looking at malignant lesions. So we have our typical moth-eaten and aggressive lesion that has broken through the cortex. We have some onion skinning and some periosteal reaction in an aggressive lesion with a pathologic fracture. To review our geographic lesions one more time, these are the least aggressive. They come in 3 flavors, 1A, 1B, and 1C, depending on how thick and well-defined your sclerotic rim around the lesion is. In a 1B, these are less well-defined. In 1C, they become even more irregular. And what we're seeing here is a lucent lesion that has some definition on the inferior aspect and no border superiorly. This is a 1B. Aneurysmal bone cyst. Notice this lesion here, very well defined in the cortex. That really helps to place this as a non-ossifying fibroma. This is a geographic 1A lesion. Moth-eaten, these are more aggressive lesions, less well-defined margins, longer zones of transition, and the differential diagnosis here will be malignancy versus infection. Here we have our example of a pathologic fracture with moth-eaten portions, and the entire bone is affected in this lesion. Here we see more of the classic portion of the moth-eaten type of lucencies that are superimposed on a large area of cortical irregularity and lucency. This is a moth-eaten pattern of aggressive lesion. Moving to permeative patterns, this is the most aggressive type of reaction that we can see. There's a rapid growth potential. Generally, it has a long zone of transition, and it may merge imperceptibly with uninvolved bone. Here we're seeing at the proximal humerus, we can see the degree of sclerosis and then the lucency along the proximal humeral metaphysis to proximal diaphysis. Notice here we can see these areas of lucency and sclerosis in this patient who has an aggressive permeative pattern involving the cortical layers. Aggressive features of permeative patterns. Moving on to the matrix, we want to further divide it into this chondroid or osseous or fibrous matrix. We're looking for the ring and arc stippled calcifications seen in chondroid or the end block cloud-like snowstorm pattern of an osseous matrix. Furthermore, matrix and cartilage tumors includes enchondromas. They can be seen in chondrosarcomas, chondroblastomas, and chondromyxoid fibromas, this ring and arc type of chondroid matrix. Bone tumor location, where we'll be looking whether or not it's in the cortex or it's eccentric. And when it's in the cortex, we can see them in non-ossifying fibromas, chondromyxoid fibromas, or even more aggressive lesions. Here is a benign lesion with expansility. We're seeing on this post-contrast coronal T1 through the ankle, this rim enhancement, this peripheral rim enhancement in this benign appearing bone lesion consistent with a non-ossifying fibroma in this case. Periosteal reaction, aggressive bone pathology that can be seen eroding or penetrating the cortex can evoke a periostitis. We can see aggressive features here in this hair on end or Codman triangle. We can see further lamellation of the Codman's triangle in something that is termed out as onion skinning or Codman's triangle, sunburst, hair on end. All of these terms are denoting an aggressive lesion, which we're looking at here. Notice there's a wide zone of transition where we can not see where normal goes to abnormal bone, the entire region looking abnormal to us. Moving on to bone reporting and data system, bone RADS category. This helps us divide lesions based on what their signal and imaging characteristics. If we can figure out what the lesion is, we can decrease our utilization costs. Bone RADS 1, likely benign, leave it alone. Bone RADS 2, this is not assessed on this particular study. We need to do an additional study. Bone RADS 3, indeterminate. We need to bring them back for imaging and periodically survey the lesion to see if it's changed, and that will be at different intervals. Bone RADS 4, suspicious for malignancy, oncologic referral and or biopsy may be necessary. To go through those plates, incidentally discovered solitary lesions, the recommendation for a lucent lesion on CT or a solitary sclerotic lesion, we'll ask some questions. Are there aggressive features? Is there pain attributable to the lesion? Is there cortical involvement, soft tissue extension, pathologic fracture, or an aggressive periosteal reaction? Yes to any of those, orthopedic oncologic referral and biopsy. No, we go through another pathway. Is there a prior history of malignancy? If there is, we want to know, we want to go on to either follow the lesion or do a post-contrast exam to understand, and we may have to do additional features of a bone scan or a PET to look for additional lesions or an MRI for further characterization. So there are different pathways we can choose. We'll continue to look at the lesion. Is the density between fat or visible fat present? If it is, it's benign, intraosseous lipoma or some fat-containing lesion. Does the lesion have ground glass? If it does, it's fibrous dysplasia. If not, is that cartilage matrix? If it's cartilage matrix, that gets to us as to another set of questions. Is it concerning? Is there any large area of lucency within it? Is there any expansile remodeling, cortical breakthrough, soft tissue mass? And if there are none of those features, we'll look at the size. Is the size greater than 5 centimeter or less than 5 centimeter? Greater than 5, bone RADS 3, less than 5, bone RADS 1. That means no further follow-up. Bone RADS 3, we're going to follow it at 6 months, 12 months, up to 24 months to establish that it's stable. And of course, if it does not fulfill those features, your bone RADS 4, you go on a biopsy. So there are many different powers to using this bone RADS category. When we have a lesion that has high T1 signal, that can have different results as well. Lesions that are high T1 can go on to be something of a cancer that has hemorrhage within it. So we want to understand that we'll be looking at 3 categories. What is the relationship of the T1 to skeletal muscle? Is it higher than skeletal muscle? If it is, yes, that's a bone RADS 1. It's a benign. If it's not, is there a post-contrast? If there's not a post-contrast exam, we'll do a post-contrast and determine whether you are benign or malignant right from that study. So it's very powerful to be able to work it out. Alternatively, is it higher than signal intensity? And is there a dropout in this chemical phase imaging? That can help us determine whether there's red marrow, and that is something that we see in BI-RADS 1. If that's not available, we'll need to either do an in and out of phase, bring them back for that, or we'll do a correlation with radiograph and bone scan. If the lesion is high on T1 and it's seen to have a fluid level, this is concerning, and we need to proceed to understand that we'll be looking at a chart that has to do with T2 images on the next slide. And this is the category we're worried about for malignancy, low T1 and high T2. For low T1 and high T2 lesions, these are evaluated aggressively if There's a history of malignancy prone to bone metastasis like breast cancer or prostate. Is it aggressive if there's pain? And we'll be asking these questions again. Is there a history of malignancy? Is there pain, cortical involvement, soft tissue extension? Any of these features, if it's yes, going on to biopsy and orthopedic oncologic surveillance. No. Is it entirely benign? Is it an enchondroma, a geode, an osteochondroma? Is it a non-ossifying fibroma or fibrous dysplasia? Answering yes to any of those categories gives us a bone RADS 1. Answering no to any of those categories, bone RADS 2 to 3. So we can see without a doubt that we have a place to stand, that we have direction by using these bone RADS categories. For our lesions that demonstrate low T2 signal, if they contain any features that are suspicious, presence of a T2 halo sign, solid mass-like enhancement, lesions close to the sternum in patients who have a history of breast cancer, or elevated prostate-specific antigen, if you say yes to any of those categories, you're going to be surveyed by an orthopedic oncologist and potential biopsy. And if no is the answer, again, we'll check again. Do you have a history of malignancy that would be prone to go to bone? If your answer is yes, then we will further work up the lesion. We'll either do a post-contrast or an in and out of phase, or we'll go on to survey and follow you over time. If there's no history, then you go to bone RADS 1, you're a benign lesion. For those low T1 solitary bone lesions, one of the powers in the statement, just to hit it home, that are considered benign for low T1 solitary lesions, if they're entirely consistent with enchondromas, geodes, non-ossifying fibromas, or osteochondromas, and they fulfill this criteria, bone RADS 1, benign. Let's take a look together now. The bottom lines for tumor assessment, we're looking at the history. Do you have malignancy? Is there pain? Morphology of the lesion. Is it well defined? Age of the patient, matrix, location, the presence of periosteal reaction, and the signal intensity, all important to assess tumors. Today, we'll talk about malignant tumors of the foot and ankle. There are 5 that we'll discuss: osteosarcoma, chondrosarcoma, Ewing sarcoma, bone metastasis, and adamantinomas. Thankfully, these are extremely rare. Osteosarcoma is the most common, followed by Ewing's, then chondrosarcoma out of the largest grouping from the Armed Forces Institute of Pathology. In British Medical Cancer Journal, they studied 7,500 musculoskeletal tumors, and they found about 413 of those cases, or around 5.5% of tumors occur at the foot and ankle. Those were included in 409 cases. They had about a half of a split for about 215 male, 200 female, 198. And they found of all these patients, 35 were malignant. Of those, chondrosarcoma was the most common in this series, osteosarcoma and Mets, 6 each, and Ewing's, 5 of those. So of this series that they studied, chondrosarcoma was the most common. For osteosarcomas, which are less than 4% of osteosarcomas arising in the foot and ankle, the mean age of presentation, 4th decade, which is later than for non-pedal types of osteosarcoma. The subtypes, intramedullary or conventional, around 80%, surface lesions around 10 to 15%, and extraskeletal less than 5%. Osteosarcoma in the foot and ankle, we're having an example here in the calcaneus. We're seeing this en bloc sclerosis, irregular portions of fragmentation, where we're seeing actual tumor extension likely when we're seeing this pattern. Here is our pathologic proven specimen. And on MRI, what we can see is that there's complete T1 replacement. Notice the T2 features of the lesion, and the post-contrast enhancement is what we're seeing here. Large areas of tissue necrosis in this patient who has osteosarcoma replacing the calcaneus. Osteosarcoma can be seen with solid, stipple-like, cloud-like, and ivory-like types of mineralization. And we can see here this en bloc evidence of sclerosis with this hair-on-end periostitis, the onion skinning, lamellated, very aggressive periostitis we see. Notice here we're looking at this lobulated sclerotic lesion with Codman's triangle denoting a very aggressive periostitis, patchy, sclerotic, poorly defined, wide zone of transition, permeative pattern in patients who have osteosarcoma. Ewing sarcoma, this is an aggressive primary round blue cell tumor. The male to female ratio is about 1.5 to 1. Commonly, the presentation is pain and swelling. Femur and tibia are most commonly affected. And classically, there can be a lytic type of destructive lesion. There can also be a sclerotic form as seen here. And the predilection is for tissue invasion. We can see here on the asterisk, this is a biopsy-proven Ewing sarcoma that's replacing the entire fifth metatarsal in this young adult. Ewing sarcoma seen here with the MRI features of this poorly defined lesion with decreased T1 intensity, paralleling the degree of sclerosis. On this T1 image, we notice the asterisk in the degree of sclerosis at the intramedullary canal. These are the more normal appearing marrow features of fat. And here we can see the replacement at the fifth metatarsal in this patient who has a biopsy-proven Ewing sarcoma. Chondrosarcoma, these are lesions that can arise from pre-existing osteochondromas from the cartilage cap that we discussed in the benign lesion category, or even from enchondromas. Patients who have multiple types of lesions, either hereditary multiple exostoses or Olier's disease or Maffucci's being enchondromas with soft tissue hemangiomas, they're at higher risk for malignancy. In the foot, lesions typically exhibit low-grade features with a potential for recurrence, and primary treatments of chondrosarcomas will equal wide surgical rescissions to be curative in the majority of cases. Chondrosarcoma, these are malignant tumors of sarcomatous stroma producing cartilage. Lesions in the hand and foot are rare and represent 1 to 3% of all chondrosarcomas. The peak prevalence is in the 4th to 6th decades, and the differential involvement from the tibia and fibula down to the metatarsals. And here we're seeing on this axial long axis through the region of the midfoot, we're seeing a lobulated cartilage lesion at the center of this midfoot. Our example again of the chondrosarcoma identified in the hand. This is a biopsy-proven chondrosarcoma demonstrating that typical hypertrophic expansile appearance of chondroid flocculent ring and arc matrix with pathologic fracture in this aggressive appearing chondrosarcoma. Our feature, what we just saw, our chondrosarcoma seen here, we can see there's a replacement at the level of the midfoot in this very large, aggressive biopsy-proven lesion that you can see further by reviewing this article. And you can see the post-contrast peripheral enhancement areas of irregularity. And here we can see the mass infiltrating through the region of the plantar arch. Chondrosarcoma is famous to have mimickers. These are lesions that look like chondrosarcoma. So we can have a variety of lesions in the calcaneus that can mask around as different things that can have a variety of appearances. In A, this is a Ewing sarcoma in a 31-year-old patient. Take a look. There's sclerosis and irregularity. In B, noticing that we're seeing this loosened area of a simple bone cyst in an 11-year-old male patient. In C, we're seeing a secondary squamous cell carcinoma. These are biopsy-proven lesions. And lastly, in D, here's a low-grade chondrosarcoma seen in the dorsal aspect of the calcaneus in a patient, an end-of-bone lesion. This is an interesting case in my teaching files of a leiomyosarcoma of bone. This is a very rare sarcoma and accounts for less than 0.7% of all primary malignant bone tumors. It carries a poor prognosis with less than a 35% survival, and it generally takes a multidisciplinary team of experts to treat this lesion. This is a case seen a year apart. Notice you're barely making out that there is some type of lucent lesion here, which is much better seen on the follow-up, unfortunately, for this patient. When we go on to do MRI, we can see that there's an extremely aggressive lesion on this axial T2 fat-suppressed lesion that's actually infiltrating through the region of the interosseous membrane, which you can appreciate here on this coronal T1 weighted image through the distal ankle, where you're noticing that the lesion not only is involving the bone, but just breaking right out into the region of the interosseous membrane. And here we can see that lesion again with greater clarity on that coronal T2 weighted image, a leiomyosarcoma of bone. Here, metastasis in the workup of that patient in the chest CT. Notice the aggressive nature of this lesion metastasizing to other areas of bone. Here we are seeing our post-contrast peripheral enhancement of this leiomyosarcoma, very infiltrative lesion at the level of the ankle. And of course, unfortunately, bone metastasis is the most common in adults. Prostate, breast, lung, kidney, thyroid, lead kettle is the mnemonic PBKTL, and we'll be looking to see these unfortunate lucent, lytic, pathologic fractures. As we see here, this is a very irregular appearing humerus. We see areas of hermitative pattern, moth-eaten pattern, and an aggressive osseous lesion. Here we're looking at a complete replacement of the odontoid process in a patient who has metastatic renal cell carcinoma. Very common for renal cell carcinoma to go to bone and have these lytic lesions in the medullary type. The metastasis can be seen from direct extension, retrograde blood flow, Batson's vertebral plexus or arterial seating, very common to have metastasis in the spine. Distribution of sites also includes vertebra, pelvis, proximal femur, proximal humerus. You're going to start, as usual, with an x-ray, but we'll move up to an MRI if we suspect a lesion in one location. And of course, we can do a bone scan to assess for multiple lesions. If the patient has multiple myeloma, we're not going to see those on bone scan. They can be quiet. We also want to recommend that the patient have a serum study, a serum electrophoresis, to study for the monoclonal gammopathy, which is often associating those patients. But here is our lesion, that renal cell carcinoma seen through the odontoid base in this patient who has aggressive renal cell carcinoma. In this case of this unfortunate metastatic patient, we had an unknown primary. We can see that there was an initial x-ray where the lesions that were occurring near the capitate and hamate were not visualized. The patient returned for follow-up, and we can see now this lytic lesion destroying the hamate, and doing an MRI proves that there's T1 marrow infiltration of the hamate. Adamantinoma, this is an extremely malignant bone tumor, thank goodness rare, locally aggressive tumor. Distant metastases are reported in about 15% of cases. 10 to 50-year-old predilection, 50% of them are young. So 50% of them occur in the pediatric or young adult population. More than 90% of them look like this and occur in the tibial diaphysis. So you can see this bowing and this very aggressive, sclerotic, irregular remodeling. 60% of them had a history of trauma, and there's a wide differential diagnosis from giant cell tumor to fibrous lesions to aneurysmal bone cyst to eosinophilic granuloma. This example of a 13-year-old with chronic pain in this adamantinoma, seen 1955, old plate, very rare lesions. We can see this sclerotic, bubbly, lytic lesion occupying a very long section of the tibia. Seen here in frontal projections, we can see this sclerotic, very irregular bone, and then this very lucent region here. Notice there's also involvement across the interosseous membrane and involving the fibula, a point that makes this no doubt an aggressive lesion, seen here. Another example of an adamantinoma seen here with these two coronal images through the lower extremities. What we can appreciate is the T2 elevated signal within the left tibia. Notice the elevated perilesional edema on either side and the slight expansility. Notice the post-contrast irregular enhancement. This is not a thin rim. There are areas of thickening and areas of thinning. So this is something that we'll be going to biopsy. We'll include in our differential looking at this. If we were originally reading this, of course, tumor versus infection, because infection or Brody's abscess can have a similar appearance in this location. And that brings us to osteomyelitis or Brody's abscess. And what we can see here is that this is a subacute osteomyelitis, smoldering or indolent infection. Staph aureus is most common. This can present with pain, geographic lytic lesion, and it's going to be an area of pus or mucus-filled cavity lined by inflammatory granulation tissue. The most common location is in the metaphysis, and then that's about 2/3. They can also occur in the diaphysis. The metaphysis, and we'll talk about why that occurs. Here's an example that I found in the cuboid. This is one of my favorite cases. Very uncommon to have a lesion in the cuboid at all. We can see this lucent lesion and this patchy sclerosis. We can appreciate that on lateral x-ray as well. Brody's abscess, the most common locations, again, the metaphysis of long bones and the 2/3 diaphysis in about a third. And the differential diagnosis of a lesion that looks like this, of course, would be tumor. Of course, we had the clinical correlation of this patient who was a sickler who had an elevated white count and fever. But what we're seeing here on the T1 is some irregular, hypointense T1 lesion, elevated signal intensity in the cuboid with surrounding edema and irregular lesion. We can see the post-contrast rim enhancement, and this went on for a CT-guided biopsy. We have our needle within the lesion, and we drained the pus and was able to identify the culture and sensitivity of this lesion and provide the appropriate antibiotic coverage. Brody's abscesses, more examples of them, can be this lucent lesion at the level of the metaphysis with surrounding patchy sclerosis, seen here. Again, seen here, we can see our lucent lesion with surrounding patchy sclerosis, a great mimicker of a bone tumor seen above the level of the physis in the metaphyseal region. So the great mimicker in carcinoma is osteomyelitis, and Brody's abscess is subacute osteomyelitis. And it behooves us to take a look at the different ways we can present with infection throughout the growing skeleton. So at the beginning of life, in the neonatal stage, we still have these transphyseal vessels, vessels that cross the growth plate. So we can take an infection that's occurring at the level of the metaphysis into the epiphysis, and in fact, that can easily enter the joint space. So about 75% of neonates that have osteomyelitis will also present with septic arthritis. In our young adults, we can also see that the apposition of the capsule is not tightly applied. So we can have infections that go from the level of the metaphysis right through the capsule and also present as a septic arthritis. And here we can see in the situation of our young adults to later adulthood where we have now fused our physeal vessels. They're no longer having transphyseal vessels. An infection that's occurring is occurring because of the slow sludging at the sinusoidal level, at the level of the metaphysis. So the takeaways from this tutorial were to provide an overview of imaging tools to assess all bone tumors of the foot and ankle. We reviewed again general principles of imaging evaluation of bone tumors, including the morphology, the age, the matrix, and the location. And then we performed an evaluation of the most common malignant bone tumors of the foot and ankle, including osteosarcoma, chondrosarcoma. We looked at Ewing's together. We assessed metastatic disease and, of course, adamantinomas. And lastly, we reviewed the great mimicker, using the diagnosis of Brody's abscess to illustrate how the different vessels and the transphyseal vessels and the application of the capsule can all lead to different patterns depending on the neonate, the young adult, and the older aged adult. I thank you for your time and attention, and there are references available for your review.